Let's jump straight into high-yield toxicology and antidotes. In this explainer, we're zeroing in on the clinical pivot points that actually dictate your next best step in management. We're talking specific presentations, underlying mechanisms, and those strict treatment branches you need to know cold for the exam.
When a poisoned patient rolls into the ED, chasing the specific toxin right away is a rookie mistake. It's rarely your first priority. Your immediate, testable next best step is always the primary stabilization sequence. Secure the airway and breathing, support their circulation, check the glucose, get a temperature, and grab an ECG before you even think about specific decontamination or antidotes. Oh, and don't forget to check pregnancy status when it's relevant.
Now, for GI decontamination, activated charcoal is a great tool, but only if you use it within 2 hours of an acute ingestion in a fully alert patient with a protected airway to decrease systemic absorption. But here is the hard stop. Altered mental status is an absolute contraindication. The aspiration risk is just too high. You also have to avoid it if the patient has an ileus, a bowel obstruction, or if they've ingested caustics or hydrocarbons.
Moving on to acetaminophen toxicity. The tricky part here is that early symptoms can be incredibly mild, totally masking the massive hepatic necrosis that's brewing. Your pivot point? You need to obtain an acetaminophen level at or after the 4-hour mark post-ingestion and plot that on the Rumack-Matthew nomogram. If that level lands above the treatment line, or if the exact timing is unclear but you have any detectable level at all, you give N-acetylcysteine immediately.
But what if things go south? If your patient develops worsening acute liver failure despite aggressive N-acetylcysteine treatment, the definitive next best step on the exam is an immediate referral to a liver transplant center. Once medical management is exhausted, transplant is the only indicated life-saving procedure.
Let's talk salicylates. This toxicity classically presents with a triad of tinnitus, hyperventilation, and altered mental status. You often see vomiting and hyperthermia too. The real hallmark here, though, is the acid-base disturbance. You're looking for a mixed respiratory alkalosis, which is driven by that hyperventilation, piled on top of an anion gap metabolic acidosis caused by elevated lactate and uncoupled oxidative phosphorylation. To treat symptomatic salicylate overdose, your goal is to trap that toxin. You do this by alkalizing the urine and serum with IV sodium bicarbonate to boost renal excretion. But you have to pivot straight to hemodialysis for severe ingestions. We're talking patients presenting with shock, seizures, severe neurologic findings, or those who simply can't tolerate the large fluid volumes required, like if they have pulmonary edema or acute renal failure. Next up is tricyclic antidepressant, or TCA, overdose. Sure, these patients might have respiratory depression and hypotension, but what really kills them is cardiac toxicity, specifically ventricular arrhythmias. The critical diagnostic clue you're looking for is a widened QRS or QT interval on the ECG. The second you see that, the immediate next step is IV sodium bicarbonate to overcome the cardiac sodium channel blockade. And if they seize, treat those seizures with benzodiazepines.
Here's a classic exam trap, confusing pure anticholinergic toxicity with TCA cardiotoxicity. Both can give you dilated pupils, dry mouth, and urinary retention. Now, pure anticholinergic toxicity can sometimes be reversed with physostigmine. But if you have TCA cardiotoxicity with a widened QRS, giving physostigmine is absolutely contraindicated. It can literally cause fatal cardiac arrest. Stick to the sodium bicarbonate.
Shifting gears to cholinergic toxicity from organophosphates. This hits you with those classic dumbbells muscarinic symptoms, plus nicotinic effects like profound weakness and muscle fasciculations. Your sequence here is critical. First, support the airway, strip off their clothes immediately, and aggressively irrigate the skin. Then, you push atropine first to competitively block those muscarinic receptors and dry up the airway secretions. Only after that do you give pralidoxime to regenerate acetylcholinesterase and reverse both the nicotinic and muscarinic effects. Let's look at cardiac drug overdoses, starting with beta blockers. The excessive adrenergic blockade tanks intracellular CAMP. Patients come in with profound bradycardia, hypotension, AV block, confusion, and bronchospasm. But here's the differentiator. Because beta-2 blockade impairs gluconeogenesis, you'll see hypoglycemia. That's your clue to distinguish it from a calcium channel blocker overdose, which gives you similar cardiac findings but causes hyperglycemia instead. And just for context, contrast both of those with digoxin toxicity, which shows up as GI upset, color vision changes, atrial tachycardia with AV block, and hyperkalemia in an acute setting. The stepwise rescue pathway for severe beta-blocker overdose is very specific. Start with IV fluid boluses and atropine. If they are refractory to that, you push intravenous glucagon. Glucagon directly stimulates intracellular CAMP production, completely bypassing those blocked receptors. If they're still unstable, you escalate to calcium gluconate, vasopressors, high-dose insulin with glucose, and even lipid emulsion for severe cases. Meanwhile, if you were dealing with severe digoxin toxicity, your specific treatment would be digoxin immune fab.
When you have a victim pulled from a structure fire burning plastics, you have to suspect cyanide and carbon monoxide toxicity. Cyanide completely inhibits oxidative phosphorylation, forcing the body into anaerobic metabolism. This causes a severe anion gap metabolic acidosis with sky-high lactic acid. Treat this empirically with 100% oxygen and hydroxycobalamin. But listen closely. Absolutely avoid sodium nitrite if you even suspect concomitant carbon monoxide poisoning, because nitrites actively induce methemoglobinemia. Carbon monoxide itself just needs 100% oxygen and maybe hyperbaric therapy. Oh, and speaking of methemoglobinemia, if you see cyanosis, chocolate-colored blood, a normal PO2 but a saturation gap, that's what you're dealing with, and the treatment is methylene blue.
Iron poisoning is a completely different beast. You'll actually see radiopaque pills on an abdominal X-ray paired with severe GI bleeding, shock, and an anion gap metabolic acidosis. Hepatic necrosis can hit within 2 days, and survivors might even develop pyloric stenosis weeks down the line. You treat this with supportive care, whole bowel irrigation, and the chelating agent deferoxamine. Compare that to lead toxicity. With lead, you confirm a positive capillary screen with a venous lead level. Then you remove the exposure, notify public health, and chelate if the levels are high enough.
Finally, you have to memorize the strict criteria for urgent hemodialysis. We're talking severe metabolic acidosis with a pH under 7.1, symptomatic or refractory hyperkalemia, and volume overload that isn't responding to diuretics. You also urgently dialyze for lethal intoxications from toxic alcohols like methanol and ethylene glycol, severe salicylate overdoses, and lithium toxicity. Keep in mind, lithium toxicity can show up as acute GI predominant symptoms or chronic neuropredominant symptoms, and it's heavily exacerbated by things that reduce its clearance. Think dehydration, NSAIDs, ACE inhibitors, or thiazides.